Right now in 2024, the absolutely only evidence base is for low desire that bothers a woman. If a woman's got low sexual desire with low arousal, with or without low arousal, testosterone does have a consistently, irrefutably, across all sorts of studies, big ones, small ones, different populations, testosterone will moderately improve sexual desire in most women, but not in all.
I'm Anne-Marie McQueen, journalist and proud 50-ish woman, and we are here looking for the true truth in perimenopause, menopause, midlife, and beyond.
Opening our minds to other possibilities is not always easy.
Hot Flash Inc.
You're all woman to me. All right, Anne-Marie.
Anyone who listens to the Hot Flash 8 podcast will know I've had a hard time finding help with my perimenopause and menopause symptoms, whether it was trouble sleeping or extreme anxiety or vagina stuff. I've encountered roadblock after roadblock in doctors who didn't know anything about taking care of women like me. It made everything harder than it had to be. That's why I'm so happy that there are companies like MIDI Health stepping into the gap and sponsoring podcasts like this one. Their supportive, comprehensive, and holistic approach to the menopause transition will provide you with what we all need most, a personalized care plan. Their virtual care clinic is easy to use and covered by most insurance plans. You can chat with your specialist during an appointment or message 24/7. You don't have to deal with this alone any longer. Book your visit today at joinmidi.com. That's joinmidi.com. Just top level when it comes to the research that's available, what are the largest studies and most reliable on testosterone and women in perimenopause?
So firstly, there's basically no data about perimenopause. Perimenopause starts from the beginning of the menopause transition to 12 months after menopause. It's very difficult to define, and that's why there aren't a lot of studies on the perimenopause. We've done 2 studies in women aged 35 to 45 who are still having regular cycles and shown small but statistically significant effects on sexual function in women presenting with low desire. But those studies were small and the effects were modest. So all the studies of testosterone pretty well have been in postmenopausal women. And the biggest studies have been with the testosterone patch. The largest was one that involved 800 women. They were randomly allocated to placebo, a lower dose of testosterone and a moderate dose of testosterone by the testosterone patch. And that study was 12 months duration. And that's the largest body of evidence we've got in that one study. But when you put it together with all the testosterone patch studies, it involved thousands of women. And that whole program.
That testosterone patch, was that in the US, the patch that wasn't approved? Is that related to that?
Yeah, it was approved. It was approved in the UK. It was approved in Europe.
Okay.
For surgically menopausal women who had inadequate improvement in sexual function despite estrogen. And the uptake was quite low. And the company wasn't really able to promote it for off-label use. It was never approved in the US.
That was 20 years ago that was rejected. What's your impression of that? It's called the Intrinsa patch.
Yeah, I mean, the panel, the majority of the panel of the FDA agreed that it was effective. But the panel appropriately said at that time, this was 2004, that there was insufficient safety data because the company truly had not generated sufficient safety data for effects on the cardiovascular system or blood sugar or blood fats. So I think the company was so sure they were going to get across the line that they hadn't really considered that people would be asking other safety questions. And those studies were subsequently done, but they never went back to the FDA.
Okay, so let's talk about your research. I want you to just, since you brought up cardiovascular, you have done research on low testosterone levels in relation to cardiovascular health.
We looked at 6,000 women aged 70 and older. I think it might have been 5,500 by the time we took out women on various medications. So in the research we do, we exclude from the analysis women who are taking medications that might alter their testosterone, which are a whole range of medications. And we end up with, I think, about 5,500 women for that analysis. And in that, what we found was that women aged over 70, so they're aged 70 to 94, the ones who had testosterone in the lowest 25% of blood levels had a twofold greater risk of having a cardiac event or a stroke. Now, that doesn't mean giving testosterone will prevent disease. We've shown that even after adjusting for cholesterol and kidney function and all sorts of things, we showed an association between low testosterone and a greater risk of heart disease. But it's dangerous to then take a second jump and say, oh, well, that means if I give people testosterone, it will prevent disease. We can't say that. That study is yet to be done.
I think your next phase of research is looking at testosterone cream and low testosterone levels in postmenopausal women and a risk of developing something called heart failure with preserved ejection fraction. Can you explain that?
Yeah. So previously, heart failure was considered just as floppy heart. So your heart muscle, you could have had a virus, or you could have had a heart attack, and the heart muscle just doesn't pump as well. It's floppy heart. But over the last few decades, it's been realized that there's a kind of heart failure where the heart still pumps out, say, 60% of blood in the chamber, but the chamber doesn't fill as much. So instead of filling to a volume, these numbers are completely wrong. No one interpret these. But instead of filling to a volume of 100 mil and pumping out 60% or 70% of that, the muscle gets stiff and only fills to a volume of 50 mil and pumps out 60% of that. So that's called heart failure with preserved ejection fraction. The heart just is getting stiff and sore. And this is becoming one of the most common causes of heart disease, particularly in women. It's 3 times more common in women than in men. It's associated with hypertension, obesity, type 2 diabetes, and it's becoming a progressively important health issue. And there is no treatment that prevents it. And so we're looking at whether testosterone will actually improve heart function in people with this stiff heart syndrome, I guess is a way of calling it. Exercise does improve it, but people who have never really exercised much rarely go out and suddenly exercise a lot. So we're looking at that and testosterone. That's a clinical trial we're doing now.
Okay. And in your research, what does testosterone supplementation, when is it supported? Right now in 2024.
Right now in 2024, the absolutely only evidence base is for low desire that bothers a woman. If a woman's got low sexual desire with low arousal, with or without low arousal, testosterone does have a consistently, irrefutably, across all sorts of studies, big ones, small ones, different populations, testosterone will moderately improve sexual desire in most women, but not in all. And obviously their sexual desire is complicated. There is the evidence that testosterone will improve cognitive function, bone health, muscle health. The data is a whole lot of mixed outcomes, a whole lot of mixed methods, a whole lot of unsophisticated measures of these outcomes. And so right now, testosterone should not be prescribed for any of these reasons because we don't know if it's any better than placebo or not.
Now, this is not a popular thing to say.
No, but there was this article in the Times newspaper this week, and it's quoting a study. They're saying 300 women were in a study, and it proved that testosterone with estrogen was more effective than estrogen alone on bone. That's a study from 1999 using a compound called methyl testosterone, which is no longer prescribed because it has nasty effects on cholesterol levels. They only found this with the highest dose, which is associating with getting hairy and acne and losing hair. And there weren't 300 women who completed the study. There were 200, and only 50 of those got testosterone. So people are and that's one study, but when you put all the studies together, and this was our publication in 2019 in the Lancet Diabetes and Endo. When you put all the data together, there is no consistent evidence of a benefit for testosterone on bone health. And people are just cherry picking the data, misquoting the publications. I could debate any side of this story and cherry pick the data, but what you've got to do is give women the truth. And some people don't want to hear the truth. We don't have the data.
This is interesting because, there was also an article in the Telegraph that called testosterone a wonder drug recently for people over 50. But
it's not.
Yeah, it's not.
I mean, okay, we have been prescribing testosterone cream for women in Australia for 20 years. All right. I first started putting testosterone implants in back in the mid-80s. We're one of 2 countries in the world with a testosterone formulation approved for women. I can freely prescribe it. And I would say more women than not, after trialing it, come back and say, hasn't really helped. I give them 6 months to trial it, and they say, I'm not going to bother continuing. It is the minority that continue in terms of sexual function. And so if you are really honest with women and don't try and, be charismatic and over-embellish the potential benefits, you get much less of a placebo effect. But in all our research, there was a very, very high-risk placebo effect, and there is with testosterone. And if you pay a lot of money for it and you're treated by a charismatic doctor, you probably think it works.
Okay, so that's what I'm going to ask is what's going on, because there are people speaking so compellingly that have amassed millions of followers. I know one who's like, I was dead inside and I just needed some testosterone. And you hear these stories over and over. And are you saying it's a placebo, or do we just not have the research yet to back up what they're saying? Are we in the middle or a combination?
So our randomized placebo-controlled trials, we looked at 800 women, double-blind placebo-controlled trial across Europe, US, and Australia, and across 3 continents. And there was no improvement on psychological and general well-being with testosterone over placebo. And when we were working with the statisticians were dumbfounded because they had never seen such a big placebo effect. Okay, the placebo effect on sexual function was huge, and also on other aspects. And there are lots of things we know have a placebo effect. We did a study a few years ago of Chinese herbal medicine for hot flushes. And we enrolled 100 women. They got active or placebo. Both were completely revolting to drink. We did the study over several months, and the placebo effect was 50% on 50% of women had a reduction in hot flushes with the Chinese herbal placebo.
Okay.
And we found that the placebo effect was greatest in women who had used alternative therapies before going in our study.
Okay.
And if you look up anything, the placebo effect is very real. Placebo is a good drug.
Then let's get to the potential risks of supplementing with testosterone, because that's what everyone always wants to know. What are the risks?
So the risks are being the patients I often see who've been told it's the Holy Grail, and they come in and they've been on all different doses and often on compounded therapy. And what they find is that they've spent a hell of a lot of money and it still hasn't done anything for them after months and months and months. So in the beginning, they think it might work, and then it does nothing. So they've wasted a lot of money and a lot of time having a therapy that's not effective. And their core problem has not been addressed, their relationship or their depression. There are women being told it's going to affect their mood, improve their mood. We did a study of women with on antidepressant therapy, we showed improvement in sexual function, but we didn't show improvement in mood. And other studies have not, placebo-controlled studies have not shown effects on mood. So women are being told it's going to improve their mood, whereas their underlying problem is not being dealt with. And to me, that is the greatest risk, is not treating the root cause of a person's lack of wellness, whether their lack of wellness be mood or whatever. Telling women it's going to improve their bone density when the overall international data does not show that. And a woman then goes on testosterone thinking it's going to protect her bones, and 5 years later finds that they've got osteoporosis. That's not fair. That's misleading, and that person can end up with fragility fractures. So it can cause harm, and the harm is not, I mean, there's very little biological harm in terms of if you're using too much, you're going to get acne, oily skin or hairiness. You're going to know you've got a problem. But, and you're going to know you're using too much. To me, the greatest harm is misleading women, not being truthful to what we truly know, having their core condition not treated, and potentially having them in a few years with bone loss and that should have been prevented that hasn't been prevented.
Are there any effects on the heart or the brain?
There don't appear to be. If women are using big doses, there don't appear to be. The other group, there's a group in the US telling women it prevents breast cancer. We haven't got that data. That's very dangerous. So I think making claims that are unsubstantiated is wrong. Women deserve to know the truth. Women are really potentially intelligent health consumers, but if they're fed a whole lot of misinformation, I think it's devious. I think it's misleading. I think it's treating women with disrespect.
So if you go on testosterone, believing this, your take is that in a lot of cases, it's a placebo.
In many cases, it's a placebo effect. Yes. I mean, the data shows that.
I have to ask you about pellets because that's the hottest of topics. And it always amazes me because I'll talk to someone who says pellets work for them. I'll speak to a doctor who uses pellets and said it works for their patients. And then there's someone else who says the pellets are the work of the devil. And then if anyone can do pellets, you should never go see them again. It's one of the most divisive issues. You used pellets in the beginning, so I'm really curious about what you think. And pellets aren't just testosterone, they're also estrogen pellets.
Yeah, I mean, I think there's a population in which whom pellets are very useful. So if we do testosterone pellets, the problem is that they were made previously by an Organon used to make them, and they're an Organon's drug company. They were around for many years, and they were approved in the UK and Australia for use in women. And they were a 50 milligram pellet. And there were studies. We published studies with blood levels. They were taken off the market when the company was taken over because they were not satisfied there was sufficient quality control in the production, and there wasn't enough sales to reproduce that. So now pretty well the pellets are compounded, or there are pellets in the US that are approved. I think they're FDA approved for men. So the problem is that when you use them, the blood levels are all over the shop. And the absorption's very variable. And some women will get very high levels and some women get very low levels and inadequate effectiveness. And there are fragments of pellets that stay in the tissues. So the pellets are inserted with local anesthetic just under the skin into the fat layers. And fragments can stay in those fat layers and start re-releasing after many years. So pellets can work. They have to be done cautiously. You can't just whack in a pellet without making sure the blood levels haven't gone back to baseline. And what we showed again in estrogen studies is that we showed with the one pellet that we got that's pharmaceutically made, the blood levels were sustained for anywhere between 3 months and 2 years. Some women we put in a pellet and we're still working 2 years later. And you have to make sure the blood level goes back to baseline before you insert another pellet. And why is that? It's because there's a condition called tachyphylaxis. And tachyphylaxis is when you get more and more and more used to high hormone levels. So I've seen women with estrogen levels in the thousands, and they're having hot flushes and night sweats because their bodies got so addicted to the hormone. So unless they're managed carefully and patients are counseled and they're done with products that have a well characterized, there is real potential for harm. And then if a woman gets, I've had patients get breast cancer with a pellet in, can't get it out. You got a level of 2000, estrogen of 2000, you got pellets in, and you got breast cancer, you're in deep trouble. And I've seen that. So breast cancer surveillance is vital if you're using estrogen pellets.
Since we're talking about breast cancer and just to go back to the wider issue of hormones, it seems that there is now a push to minimize any and all talk of any relation of risk of breast cancer to hormone therapy. And there's a lot of confusion over that. And like you said, there's a group in the US and they're talking a lot about hormone therapy can prevent breast cancer. Can you just give me your take on that? Because that's probably the number one question that I get.
We don't have the data. So in the Women's Health Initiative study, estrogen only using Premarin, pregnant mare's urine tablets, there was no increased risk of breast cancer and a borderline not statistically significant reduction. We, include myself, have tended to generalize that to all estrogen and say to women, if you've had a hysterectomy and you're using estrogen only, it probably has a negligible or no effect on breast cancer. If you're a purist, you would say that's a dangerous generalization because pregnant mare's urine tablets contain a whole array of different estrogens. They're a hormone cocktail, and some of the components in that tablet actually block estrogen receptors. So Premarin is it's a hormone cocktail that even has some anti-estrogens in it. So can I truly put my hand on my heart and say, absolutely, if you use an estrogen patch and you've had a hysterectomy, it does not increase your risk of breast cancer? If you're a purist, you'd say, no, I can't do that. It probably has a minimal or no effect, but that's a bit of a risky extrapolation. Then if you use estrogen with progestogens, the synthetic one, there appears in all the studies, doesn't matter how you slice it and dice it, to be a small but a real increase in breast cancer risk. When it comes down to the individual, it's probably small. It's probably very small. And everyone's pushing that progesterone is bioidentical and natural and does not increase the risk of breast cancer. We do not have the data. And I think I cannot, if you say to me, so I want to use an estrogen patch and progesterone, does that increase the risk of breast cancer? I can say to you, there may actually be a small increase in risk, but we don't know.
Okay.
And that's the data.
Okay. It's not correct to say there's no increase.
No, there is no correct. People refer to studies with 20, there's one famous study where there were 20 women in each arm and they did breast biopsies and they looked at cell activity in breasts. And it was less with an estrogen patch and progesterone. 20 women. And that's not a breast cancer diagnosis. I'm like, really?
And we don't know what women are also doing. Like if you're still drinking alcohol, if you're still doing some of those other things, can you speak to that a little bit? Yeah.
Yeah. I mean, being obese is associated with a 40% increased likelihood of breast cancer. Val Beryl's stuff from the UK suggests that the biggest risk is having obesity, and estrogen probably is neither here nor there in that setting. But I think to say that there is no risk of breast cancer taking hormone replacement therapy in somebody who goes through menopause after 50 you've got to be very cautious. That I think that's an unfounded statement.
Can I just ask you about testosterone for genital syndrome of menopause? There was a nurse practitioner who presented on this in 2020 or 2021 to the Menopause Society. And Brooke Fott, she lives in Nashville, and she spoke to me about how it really helped her patients with some of their symptoms, including some of the things we don't hear about, like muted orgasms and disappearing orgasms and things like that. Can you speak to that at all?
The very first use of testosterone in women in the 1940s was for vaginal atrophy. And there's some early studies where women were injected with high doses showed improvement, and they got high doses. Intramuscular injection showed actually improvement in the lining of the vagina cells. We did one study. We did the only double-blind placebo-controlled study of women. We gave vaginal testosterone to women who have breast cancer taking the aromatase inhibitor, so they couldn't convert the testosterone into estrogen. And we wanted to see the effects of testosterone. And women reported reduced sexual pain, increased lubrication with the testosterone. But we saw no changes on vaginal smears to look at the vaginal cells. So we think it's probably due to increased blood flow. So there is potential benefit. It hasn't been studied in large numbers of women. Again, you need to make sure that the testosterone is very low dose, and probably some is going to be absorbed, because we know the vagina is very good way to absorb things. But it shouldn't be standard therapy, but it is potentially beneficial.
Okay.
We need more research.
I'm going to butcher this word. Dehydroepiandrosterone, DHEA.
Yeah.
That's sold as a supplement, and wherever people are listening, it may or may not be available. This uses the body uses this to make androgens and estrogens, correct?
And estrogens.
Okay, so how does that fit into everything you've been studying?
There have been 3 very big randomized placebo-controlled trials in people with normal adrenal function and showed no benefit. It's the bottom line. No benefit for cognition, for vasomotor, hot flushes, night sweats, for sexual function, for muscular function, a whole range of things. Some very early studies suggested there might be some benefit for bone, which is probably being converted into estrogen in the bone. But I think probably the real reason you don't see benefit is that DHEA is converted predominantly in skin and fat, and also in other tissues, into testosterone and estrogen. And then it's re-released from the skin and fat tissue into other tissues like the brain and blah, blah, and other tissues. And the testosterone has to be made in the skin to then go into other tissues. And to get a dose that was effective enough, you're going to get oily skin and acne and hirsutism. Okay. So, but we did a randomized placebo-controlled trial of over 100 women, and we looked at everything. We didn't look at cognition, but we found no benefit. The Colorado Health Sciences group did a big study, found no benefit. The Mayo Clinic study found no benefit. So in the 1990s, everybody thought it was going to be the elixir of youth, but that didn't prove to be the case. And in fact, the company led by Ferdinand Labrie from Canada, who was going to go into production for DHEA, was going to save women, stopped all the trials because there was no benefit, but did develop the vaginal DHEA for vaginal symptoms. It's approved in the US and Europe.
And that does work, or
except it has to be used every day. When they did a study looking at being used 3 times a week, it didn't work. So women have to use a vaginal insert every day, and that's a bit sloppy.
Yeah, every day forever.
Well, yeah, literally.
Yeah, just, yeah, I can see why that doesn't appeal. I don't know whether you want to wade into this, but you mentioned the pill, the birth control pill, and its effect on the ovaries. I'm just always curious about our mass use of the pill and how that affects us later on. Do you have any thoughts on that? Have you done any research on that?
I haven't, but I don't look. It's sort of, firstly, there are so many different formulations and types of pills and doses. Secondly, there are a whole lot of different reasons people use the pill. it has been shown categorically that people who use the pill are less likely in later life to get ovarian cancer. So it is protective. There's no question. Whether it has other effects in later life is not known. But, and its effects on sexual function are mixed. If the one study suggested that women who pill users had low libido. But on the other hand, if you go on the pill because of severe menstrual cramping, pain, bleeding, it's likely that it'll improve. And we did a study where simply switching brands of pill improved libido. So there's a placebo effect for you if there ever was one. And so I think it depends why you're on the pill, what your needs are, whether you have benefits. If you're on the pill because it gets rid of menstrual migraines, if it gets rid of PMDD, if it gets rid of heavy bleeding, you'll probably benefit.
Yeah.
It's very mixed.
So I feel like we're in this space where we don't have enough research, particularly with perimenopause. And this is just speaking to overall hormone therapy. You have hormone therapy treatment for symptom relief. You have hormone therapy treatment possibly for prevention. And then I think there's a new emerging area, which is like optimization, almost like a biohacking type thing. And the thing is, we don't have evidence for a lot of that, right? But there are wild claims being made about all of it. I just wanted to, with someone from your lengthy experience looking at sort of the climate now, what would you say to women who are trying to figure out what to do?
I think the single most important, I think the clearest indications for hormone therapy are for symptoms that are bothersome: hot flushes, night sweats, sleep disturbance, new onset low mood, not depression. Vaginal symptoms can often be treated with hormones alone. So then I see the patient who comes and says, I haven't had a period for a year. Should I be on hormones? I will then check their bone density. And we've actually published algorithms to suggest that internationally endorsed algorithms looking at bone density and saying at this point it would be reasonable to introduce hormones. The evidence that hormones will improve brain fog, muscle function, depression, fatigue, in women with none of those other symptoms is lacking. And, there was one study published years ago of all the things that contribute to dementia. It's massive. And I think this term brain fog's just being it. My 37-year-old stepson, we were talking about the most overused terms of 2023, and he came up with the term brain fog amongst his peer group. Everybody's owning brain fog and everybody's looking for a cure for it. ADHD owns brain fog. Young people own brain fog. Stressed people own brain fog. And I think this argument that hormones are going to fix everything is completely and utterly naive. Life is complicated today. And, it's not a magic bullet for inadequate sleep, stress, multitasking, etc. And I think that it's part of a jigsaw of good health.
Yeah, you spoke earlier to, what's the root cause of your mood? And when I look at the way people are speaking, it seems like if you take something, then maybe you don't have to get to the root cause of your mood. And that's not a popular thing to say. It's almost like you're not on the side of women if you suggest that there might be a root cause to their mood and feelings of being dead inside in their 40s. Do you know what I mean?
Oh, and believe me, I've been through menopause. I know what hot flush is like. I know what sleep deprivation is like. I know what feeling a bit black and blue is like, and that hormones, that estrogen can help. But it's not going to. But there are also lots of reasons. It doesn't mean that every night I have women come back and say, but some nights I still don't sleep well, and it's not because of their hormones. It's because there are other things happening in their lives. And it's even been put to me that part of the trend in testosterone has been that people have advocated for hormone replacement therapy, and then women are coming back and saying, still don't feel great. Why don't I still feel great? Try some testosterone. This is going to fix it. So what's going to be next? Growth hormone?
Mm-hmm.
You know, when women come back and say, well, I've tried estrogen, I've tried testosterone, but there's got to be something else wrong with me. And I think we all have to accept, you know, life is complicated and it's never just one thing. It's rarely just one thing. And hormones are not going to fix everything.
What are you excited about studying next?
Oh, I mean, we've done a big cross-sectional study of 8,000 women we're looking at now, looking at menopausal symptoms and work. And we've got the women have been recruited from across Australia, across all socioeconomic groups, geographically representative of Australian women. And we've collected validated questionnaires of a whole lot of stuff. And we're really interested in seeing what's the contemporary experience of menopause in Australian women at the moment. How does it affect their mood, their well-being, their sexual function? So we're looking at all that now.
Oh, that's exciting. And there's been movements in the government in Australia for menopause awareness and policy making. Have you been involved in that?
I'm like others, I've given evidence before the Senate inquiry, and it would be interesting to see who they listen to. I mean, you know, there are a lot of interest groups in this space, which is, I think the fear of breast cancer with hormone therapy opened up this big space where a lot of people jumped in, and how menopause is being commercialized. And it's very hard for women to see wherein lies the truth. And that's really social media, influencers, commercialization, alternative therapies. It's just become a minefield for women, and it's really tough. I mean, one of the best things to read is Kaz Cook, who's written books about women's health, and she's just great. She's a comedian, but she's also a journalist, a very serious journalist. And she really advocated for women and said, you know, why are all these unrestricted practices allowed? Why are people allowed to give hormone therapies and call it something hormones? I haven't said it because I don't want to say the brand name. And tell women that this alternative therapy is going to fix them. Why are women being able to be given unstudied doses of compounded hormones or high doses of even approved hormones and told that they're safe and effective when these hormones have never been studied, and it's just cowboys out there making money and preying on women? How are women allowed to be not protected? And it's become a real battleground, which is very sad. It's sad for women.
As a journalist, I know the impact of what you can't see, which is behind the scenes, public relations, high paid public relations consultants shaping messaging in ways that we don't know. I can just open the newspaper or listen to a news program, but I don't know that the average person can spot that. Do you see that as well?
Oh yeah. I mean, some of the influencers, including some of the doctors who are acting as influencers, they've got to have great comms people working for them. There's no way I could do my job and be on Instagram every day without having a comms person come into my office at 5:00 every day and say, hey, Sue, what can we do for Instagram tomorrow? What can we get out there tomorrow? What will we say? I mean, they've got to have a whole team producing them.
Mm-hmm. Mm-hmm.
And then you've got to say, why are they doing this?
Yeah.
Don't they have a life? You know, I don't know. So I think women need to be very cautious health consumers. And if there's somebody Instagramming constantly telling you stuff, ask yourself, why is this person doing this? Why do they need to create their own profile that's a huge social media profile? What are they getting out of it? And what's their goal?
I think I always just tell people, ask if someone's got some sort of financial gain, right? If there's a gain seen or unseen from the message that they're portraying, then that's time to be careful. Just follow a bunch of right? And
Yeah,
also, the best scientists and doctors are not on social media. The people I talk to who know the most are not on, they don't, you guys don't have time.
you don't have time. You really, I mean, I've been under the pump regarding this craziness going on around testosterone. And people are emailing me at night saying, you got to write something. I'm like, I don't have time. I've got to stick with the core business, and certainly not on Instagram.
Well, I appreciate you taking the time to speak to me about that, because about this. It's really important to go in depth. The little clips will just kill us. They'll just overwhelm us with little bits of information that add up to nothing. So I really appreciate it. Thank you so much.
Well, pleasure to talk to you. Thank you for giving me the opportunity to speak. And I think all I can advise women is to go to credible places. The International Menopause Society has great information that's all evidence-based. The British Menopause Society, the Australasian Menopause Society have really great consumer leaflets that are all evidence-based and have been through lots of peer review. I don't write them, other people write them, but go to good evidence to get your information.
Okay. Thank you so much. Appreciate it.
Okay. All the best.
Hot Flash Inc. was created and is hosted by Anne-Marie McQueen, produced and edited by Sonia Mack. The information contained in this podcast is intended for informational purposes only and is not intended for the purpose of diagnosing, treating, curing, or preventing any disease. Before using any products referenced on the podcast, consult with your healthcare provider, read all labels, and heed all directions and cautions that accompany the products. Information received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem, i.e. menopause or anything else, or any healthcare questions, please promptly see your healthcare provider. This podcast, including Anne-Marie McQueen and any producers or editors, disclaim any responsibility from any possible adverse effects from the use of any information contained herein. Opinions of guests on this podcast are their own, and the podcast does not endorse or accept responsibility for statements made by guests. This podcast does not make any representations or warranties about a guest's qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have direct or indirect financial interest in products or services referred to herein. This podcast is owned by Hot Flash Inc. Media.